I won't take up too much time because I want to introduce Dr. Dean. We're so very lucky that he's here. I've heard him speak a few times, and he is full of just incredible, easy to access information. So I'm really hopeful that folks will enjoy this evening. Dr. Dean is a professor of urology at the GW School for Medicine and Health Sciences. He graduated from his urology residency from Walter Reed Army Medical Center. And after a tour with the 28th Combat Support Hospital in Iraq in 2003 to 2004, he returned to Washington, D.C. He returned to Walter Reed, and he was the director of andrology there. And in 2006, he was selected to be the program director of the urology residency program. And I say all this just so that you know that, as I mentioned, he's incredibly accessible in the information that he'll give, but also he has an extensive background in andrology and urology, which is so helpful when he talks about some of the topics that he's going to talk about this evening. He has done a lot of work with people who've been impacted by prostate cancer and sexual health, and his interests include treatments for erectile dysfunction, medical management for erectile preservation, Brony's disease, testosterone replacement care, and male infertility. He is willing to take questions throughout his presentation. So I just want to remind folks that there is a chat feature and question feature. If you can place your questions in there as they come up, he will answer them throughout the presentation and at the end. And just as a reminder that any of the information he gives tonight isn't medical advice. We want you to check in with your medical team, but will be a great overview that will help you take questions to your providers or maybe just better understand some of the typical processes. So I will pass it over to Dr. Dean.
Hi, everyone. Thanks for that great introduction. It's a little embarrassing to hear some of that stuff, but I'm happy to be speaking to you all about what I do and what I think about, especially when I see a gentleman with the history of prostate cancer, and then we want to improve his lifestyle, maybe because he needs testosterone or he has low testosterone, or maybe because of sexual health issues, so erectile function, or Peyronie's disease, which can happen after surgeries to the pelvis. And, you know, what my thoughts are about that unique patient population. And the reason why I think this is such a debatable topic, or such an interesting topic really, is because there's been a lot of concerns about testosterone therapy in men with prostate cancer. And I do have a slide presentation, but I was reviewing the slides and they're kind of scientific, and I'd rather not, you know, use them. I wish I put more graphic pictures and such. But I think I can summarize this for you all in about 10 or 15 minutes. And I really feel that with the webinars and when I speak to patients as a group, I feel that when you ask questions, I can answer that much more clearly for everybody in the room. So please, you know, type in a question or ask a question if you have one. But let me just, you know, speak to you about my thoughts on testosterone care in a patient who has the history of prostate cancer. And we have to go back in time a little bit. We have to go back to 1940 to the 1940s when Huggin and Hodges did a landmark research paper that demonstrated men who have metastatic prostate cancer, if we take away their testosterone, then their cancer goes into remission. And that was a massively important research article because it gave us a treatment option for gentlemen who had metastatic prostate cancer. And up until that point, there were very, very, very few choices. Of course, that was back in the 40s, and we're now 80 years past that. That study that they presented won them the Nobel Prize for medicine. So it's just not my opinion that this revolutionized care for men with prostate cancer, but obviously it won over the Nobel Prize Committee. When you look at that study, however, it wasn't very large. There was maybe 8 men in that study. But the men in that study all responded to the stopping or their treatment of lowering their testosterone so that their metastatic prostate cancer would go into remission. So a couple key things here. These are men with metastatic prostate cancer. This is the 1940s, and this is the first treatment we have for prostate cancer. So for metastatic prostate cancer. So all well and good. But from that, people kind of extrapolated, physicians included, that testosterone and prostate cancer should never go together. And even the FDA has a warning on treatment of men with prostate cancer. They have a black box warning that says we're not allowed to give testosterone treatment to a gentleman who has the history of prostate cancer. And that was the general consensus for men with prostate cancer for decades. And then in the 2000s, some research was coming out, mostly out of Mass General and Abe Morgenteller's group, that challenged that whole theory that men with a history of prostate cancer can never have testosterone therapy. So let me give you a little case study. If a gentleman has prostate cancer in 2003, and we do a prostatectomy, which is a very advanced surgery, and it advanced greatly during the 80s, 90s, and into the 2000s, especially now with the robot and all those wonderful techniques, and we make them cancer-free. And then his PSA goes to 0, which is wonderful. And he comes in and we're working on his we're working on his erectile function and continence. And we draw a testosterone level maybe 6 to 8 months after his surgery. And we find out that his testosterone level is low. Let's give him a number of 210, where the normal testosterone for a gentleman in their 50s and 60s should be above 300. And in my clinic, I prefer them to be actually above 350. So let's say he's 210 on his testosterone level. Most of us would recommend that he get testosterone therapy, although he's got this history of prostate cancer. So the FDA has put out that warning, and we've been taught since the 40s that we really can't give him testosterone. Well, in Mass General, they fought that. They gave men who had the history of prostate cancer and had surgery and were disease-free, they gave them testosterone therapy if they were hypogonadal, if their testosterone was low. And what did they find? No man who was given testosterone after their surgery had recurrence of their cancer. So that was kind of earth-shattering because of this dogma, of this whole belief that testosterone therapies and prostate cancer can never go together. Well, he just proved that gentlemen who had surgery could have testosterone. What he also did is he continued to follow these men, and then he started to expand along with other research groups. So everyone, that started to open up the floodgates, and we had to now start to rethink our whole dogma about testosterone care in a gentleman with a history of prostate cancer. So other research groups looked at patients with radiation therapy. Could we give them testosterone care if they needed it, if their testosterone was low? And the answer was yes. That was a therapy that we could give, and their cancers did not come back. And then we even gave it to men who had low-grade prostate cancer. And then those groups, the rates of prostate cancer growth was equivalent to the men who did not get testosterone care. So this whole idea about not being able to give testosterone treatment to a gentleman who has prostate cancer history has now actually been turned around. Now, there's some caveats here. Remember that the original study done in the 40s was with men who had metastatic prostate cancer, and that still is true. So if a gentleman has metastatic prostate cancer, giving them testosterone therapy is not recommended. However, a gentleman who has had prostate cancer and he's had surgery, radiation, or is on observation, and he has low-grade prostate cancer, giving them therapy can be performed. You have to be monitored, and we have to watch closely what your PSA does and what your testosterone does, but it has now been shown that that can be done to men who need testosterone therapy, regardless of the fact that they've had prostate cancer history. And so with that, we know that as men age, our testosterone does fall slowly. So we lose about 10% of our testosterone every decade of life. So we shouldn't go from a normal of 550 or 500, and then 2 years later, our testosterone is now 280. That's not normal. So when a gentleman has a lowering of their testosterone to subtherapeutic levels, or what we call hypogonadism, then testosterone therapy can help them with muscle mass, bone strength. It decreases bone fractures. It helps with cognition. It can obviously help with sexual function and sex drive. So it's not, it's not a magic bullet. Testosterone therapy isn't for everybody. It's for people who do have generally low testosterone. So we look at that with patients who have like diabetes, or they might have obesity, or they might have fatigue or other chronic illnesses. Sometimes their testosterone levels will fall because of those other illnesses. And sometimes by replacing the testosterone, we can bring a better quality of life. Now, I just summarized something in about 5 minutes that took decades of research to really understand. And we're still not fully understanding everything there is to know about testosterone replacement. But for certain patients, it is a very important therapy to have in our toolbox to help them in recovery after prostate cancer, again, if they need it, if their testosterone is low. So that's something that if a gentleman comes to me and they have fatigue, or they have poor sleep, or they have poor sex drive, that's something I definitely check. And if they are a prostate cancer survivor or a prostate cancer patient who's on observation, then we have to have a very detailed discussion about whether or not testosterone is right for them. But I think in 2024, that discussion should always happen. Gone are the days, or I hope gone are the days, where a urologist or an endocrinologist will just say flat out, oh no, you had a history of prostate cancer, so you can never have testosterone. I think over the last 20 years and the research that's been done in this field, we've proven that this can be done, and it can be done safely, but it needs to be discussed in detail. And so that's one of the topics that I wanted to try to address in this webinar, the therapies that we do for testosterone replacement when a gentleman needs it. The therapies are not simple. It's not a pill, although there's a new pill available now, which is interesting, and we can talk about that a little bit. But testosterone therapy in general has always been injections, but we teach men to do those at home. There's also long-acting injections, so an injection that would last 10 weeks. So that's 5 trips to the doctor, so we could do that injection. There are gels that a man could rub on his skin every day to deliver testosterone. And then there's pellets that we can put under a man's skin, and the pellets slowly dissolve. And as they do that, they slowly release testosterone. And then there's also a sub-Q injection. So intramuscular injection is the usual treatment. But now there's a new sub-Q injection, a small needle that men can do once a week to replace their testosterone, again, if needed. And testosterone replacement isn't just for sexual health. It does help with that, but it also helps preserve muscle mass and bone strength and cognition. So brain function and concentration and sleep habits all improve when the testosterone levels are in their normal range. So those are the treatment options, mostly for testosterone care, and that can be done either by an endocrinologist, can be done by a urologist or a sexual health urologist, but it's something to be considered if sexual functions are diminished, even in patients who've had prostate cancer treatments. And so that brings me to the next topic of sexual health after prostate cancer therapies or prostate cancer observation. as many of you probably know, that prostate cancer therapy, especially surgery and radiation, does put erections at risk. The nerves and the blood vessels that would help a man get an erection are very close to the prostate. And so with therapies to the prostate, radiation and surgery, those nerves and blood vessels are at risk. And then we wait for recovery of sexual function after radiation and surgery. If erections are not present right after surgery, then we would recommend using medications and even injections to help with erection function. If men start to recover and regain their function, their sexual function with erections after the surgery, well, then the medications can be limited or discontinued if not needed. And that can happen in about 50 to 60% of patients after surgery. They can recover their sexual function, but it can take up to anywhere from 9 months to 2 years to see that recovery. So we don't want to, in that time frame after surgery, we don't want to just wait. We want to help with other therapies to regain their erectile function back. With radiation patients, the same is somewhat true, although radiation effects can kind of accumulate and take longer. So some gentlemen after radiation will still function well, but they'll start to notice a diminishment in their erections at the 9-month mark or a year mark. And that's when we want to start using the medicines to help with erections. So again, the medicines that we use are the PD-5 inhibitors, which almost everyone's heard of these days. So that's the medicines like Viagra, Cialis, Levitra, and Stendra. If the pills aren't beneficial, there's injection therapy. So that's injections directly into the side of the penis that will dilate blood vessels in the penis and help with erections. That is taught through the urology clinics, and we teach men how to do that at home. That works directly on the blood vessels and the blood flow in the penis and can be a very good therapy. That therapy has been around since 1983, so it's kind of stood up the test of time. There is gels that men can put into their urethra or pellets that they can put into their urethra that can dilate the blood vessels of the penis, and that can help with erections. And then there's also surgeries, penile prosthesis, to put in a device that can help with erections. So all those are available and should be entertained or thought about for sexual healing after surgery or after radiation. And also as a man ages, and if there's other diseases that are present, like diabetes or hypertension or high cholesterol, then that can also affect erections, and those therapies would apply for those patients as well. So those are the general therapies we have for erectile dysfunction for any man, but particularly the man who's a survivor of prostate cancer. So I've noticed there's a few questions, so let me see if I can pop those up. So one of the questions is, so what if you've had radiation therapy followed by Eligard treatment to intentionally lower your testosterone? Are you saying you're not in favor of that treatment? No, I'm not saying that. That is a very good therapy. Usually the Eligard treatment would be just for a specific period of time. So the Eligard therapy is used to help shrink the prostate gland, and that allows the radiation to be more focused, and you can get better treatment with the radiation. Then they may leave the Eligard on for another year or two and then stop. And then what I'm saying is after they've stopped the Eligard, we would expect your testosterone to come back to normal range. And if it doesn't, at that time, I would recommend that we consider testosterone therapy. But that's, again, after all your therapy, your treatment for prostate cancer. So I'm not saying that I don't agree with that therapy. I do agree with that therapy because it can make your radiation therapy more robust by giving you the Eligard treatment during that time. There's a follow-up to that question. As a follow-up, what treatment would you recommend if you're on Eligard and need help with sexual function? Well, again, you're on the Eligard to help make the radiation treatment more robust and more effective. So we have to leave that alone because we do want you to have complete treatment for the prostate cancer. But while you're on those treatments, it doesn't mean we can't help you with erections and sexual health treatments that might help with orgasm in erection. So again, all those erection therapies I kind of mentioned, the PD-5 inhibitors like Viagra, Levitra, Cialis, and Stendra. There's some medications that I use to help men with orgasmic function. So those medications are Wellbutrin or Emmetadine. So these are pills that can help with the threshold to reach orgasm, and that helps with sexual function. And then we sometimes have to use those injections, penile injections, or penile urethral suppositories to help with erections. And when a man gets an erection, even though the testosterone might be lower, the erection does help with stimulation and helps with arousal. So for those gentlemen who are on Eligard, I can't give testosterone therapy until you're off the Eligard, until your full therapy has been finished. But we can do other things to help with penile erection and sensation and possibly even orgasm. Okay. I was gonna, with my slide set that I did have, there was a couple studies that demonstrates what we do and how we do it in terms of monitoring somebody who I might give testosterone therapy to after prostate cancer treatment or with a history of prostate cancer. So obviously, when we start testosterone therapy, we have to watch the PSA. And if we kind of monitor those levels, we can always then decide what amounts of the therapies we need. And so it's a kind of a balance, and this is kind of true even with gentlemen who don't have prostate cancer. When we give testosterone therapy, we have to be careful for PSA levels, but we also have to be careful for blood counts, because sometimes the testosterone therapy can elevate your red blood cells. And people that follow sports and understand what doping is, you would say, well, wait a minute, red blood cells would be good. I'll have better oxygenation and I can run farther and I can ride my bike farther. And I think what I'm talking about. But it's in truth, if we raise your red blood cell count too high, that can make your blood flow very sluggish. And that's not good for your heart function or for your lungs. So we always have to monitor your blood counts basically when you're on testosterone. Okay, and I think there's a question in the chat. Is consideration of testosterone therapy contraindicated in men post-radiation therapy for the prostate, as well as radiation for local nodal metastasis identified only by PSMA scan? Well, that's a great question. It is not counterindicated for a man post-radiation. And if they have treated the lymph nodes for a possibility of prostate cancer in the lymph node via PSMA scan, and then we've seen that follow-up scans demonstrate no cancer, or the scan is now negative, then we could give testosterone therapy. It's controversial to give testosterone therapy in the face of metastatic disease, and that's a discussion that we would always have to have with our patient if we're going to do that. I have a few patients who I have been giving testosterone therapy to with metastatic disease, but they fully understand the risk. And, it's a balancing act between, having a man have enough testosterone and energy and bone strength, and then also balancing the risk of prostate cancer. And so I think with close monitorization, we can do it fairly safely, but it's always a risk for somebody, again, with metastatic disease. So again, if somebody's had radiation therapy and their PSA is nadir, then we can give testosterone therapy, or manage to feel that you can do that. With radiation to nodal disease, I would recommend that we see the nodal treatment, the nodal radiation be effective, meaning that the PSMA scan has gone to negative before considering testosterone therapy in general. So these are some generalities. A lot of these cases of gentlemen who have the treatment for low testosterone for their cancer, we have to take by case basis. The next question is, other than shots, any recommendations for venous leak post vasectomy? Okay, good. Pills have been ineffective. though they were effective pre-surgery, and shots are unpleasant and reduce intimacy due to the transactional level. That's true. So with injection therapy, it does take away spontaneity. It's an erection that automatically happens. You don't need a necessarily arousal for the injections. Venous leak is I see a venous leak, unfortunately, in young men too sometimes, or men after trauma, and it's a difficult thing to counterbalance. So venous leak basically means you're filling your penis with blood, but the blood then comes back out through the venous leak. So the penis gets full, but it never gets rigid. And one of the mainstays for that therapy has been injection therapy. So that is a reasonable option. Because what we're doing there is we're overpowering the leak. So I kind of liken it to a patient's or anybody's sink. If you leave the sink open and turn the faucet on, the sink won't fill. But if you turn the faucet on hard enough, then you can get the sink to fill. And so injection therapy can often do that. We can overpower the leak. Pills generally aren't strong enough for that. Sometimes I would recommend that men be placed on daily Cialis therapy because that would always give a little bit of a background flow to the penis, and that can help with penile healing. But then if we use injections on top of that, then they usually have a better effect. Other than the shots, though, the next treatment option would be penile prosthesis, which of course is a surgery to put inflatable rods in a man's penis so that he can get an erection when he wants. I will tell you though, the surgery is very good, penile prosthesis, but it's usually done for men who have tried other things and these aren't beneficial. So if you look at gentlemen who have a penile prosthesis and ask them how satisfied they are with their surgery, it's above 90% satisfaction, which is actually very good for a surgery of that nature. But you have to also remember they've tried other things and it wasn't beneficial. So this was kind of like the last option they wanted, and we did it, and it works. So that makes them pretty happy. All right. So let's see if there's another question. There's a couple more questions. Let's see. Okay, question is, I had a radical prostatectomy in June of 2019. My post-op PSA gradually rose from 0.01 to 0.07. In pursuing the 5 years, I've had some ED issues since I was 56. I'm now 71. They tried treatment with PD5 inhibitor therapies and quad mix. Quad mix is the injection therapy. After surgery, I did the recommendation rehab, which was daily Viagra and a pump. I think he means external pump, which is a reasonable treatment, although I will say not as effective as other therapies. But I never recovered my potency. I could still have orgasm, and that's true. Orgasm, interestingly, is a brain function. So with the right stimulation, men can reach orgasm without erection. And that's a good thing. I mean, that's good that neuro system is still in play and still working. But I've not been able to have penetrative sex for over 5 years. Quad mix ended up giving me Peyronie's. Peyronie's disease is scarring of the penis, especially the collagen within the penis. Injection therapy, there is a 5% chance of penile scarring or fibrosis. So it's a low risk, but nonetheless, the risk is there. Surgery also shortened my penis by 2 inches. That's a combination of factors. When men lose their erections, the penis is not repetitively getting stretched, so the penis will become atrophied or smaller, so shorter. Extremely damaged, disappointed. And of course, the wife, this is an interesting quote, and I hear this all the time. So this is a very good, whoever wrote this little segment to me, I appreciate it greatly because you're touching on so many things I see in my clinic every day. The wife says, quote, "At least you're alive," unquote. And that's true. Many women feel like, you're here, sex was icing on the cake. We don't need that. Most men will say, no, the icing is the best part of the cake. So I want that back. And so it's a very interesting marital discussion. But honestly, if I had known all these side effects, I wouldn't have the surgery. I already just talked about implants. Yep. And if I stretch my penis out, it only increases to 4 inches now. Not worth it. Any help for me. As of now, I won't. Okay. So thankfully, did not. I forgot my 25. So basically, uh, poor erections after surgery, and there is some penile shrinkage and maybe Peyronie's disease. Well, my recommendation, and then there's a lot of different ways to approach this. You've tried medical therapies, you've tried injections, and those are not beneficial. I think you should definitely think about a penile prosthesis, but in preparation for the penile prosthesis, I would have you go back to your pump device, because there is a very nice study that shows if men do the pump device, so I'm talking about the external vacuum pump, if men place that over their penis and get stretch on their penis for about 5 to 10 minutes daily for 3 months, that can add an inch to their penis in preparation for a penile prosthesis. So by doing that therapy, the pump therapy, and then scheduling a prosthetic surgery, we can place in a larger prosthetic, and with the prosthetic, you'll have rigidity, and that would allow you to have penetrative sex. And I think that's a very good option for a lot of men. Of course, that has to be discussed with your surgeon and with your urologist. Is there other diseases that we worry about for the surgery, like diabetes or high blood pressure? That all should be managed. The surgery to put a penile prosthesis in only takes about an hour and a half. This obviously the penile prosthesis has to heal in place, so you can't use the device for about 6 weeks. Sensation to the penis and sensation for orgasm is still present. It's very interesting that the sensory nerves to the penis are pretty much on the skin level in the glans penis, the head of the penis. Most men figure that out pretty easily. And so orgasm is still very possible. And with your penis on stretch, you can get more sensation and more climax. Additionally, with a prosthetic, then it's going to pretty much work because you've tested it out. As you heal, you test out the prosthetic and pump it up and see what it looks like and see how it feels. And so when it comes time for actual penetrative sex, you kind of know what to expect. And so I think that brings back some spontaneity, because when you want to have the erection, you pump up the prosthetic, which takes about 30 seconds, and then you're off to the races and you do your thing. So I would consider that for the gentleman who's had surgery and is not doing well with injection therapy and may have penile curvature, because the penile curvature could also be corrected during the prosthesis surgery. But I would really have him consider doing the vacuum pump device for about 3 months before the surgery to gain more length, so we could put in a very good size prosthetic. All right. Next question is, I had radiation 3 years ago. Good news, PSA has dropped significantly. So when it does drop, we call that the nadir, the PSA nadir. And this gentleman had a very good nadir at 0.17. But recent blood tests show testosterone has dropped below normal. What you should use after the next step, and who should I talk to? Potential ways to address this. Well, you want to talk to a urologist who specializes in sexual health. You want to also maybe consider talking to an endocrinologist. So if your testosterone again is low, and by laboratory definition, the level of low would be less than 300. For some gentlemen, 350 is used. And if it's low, then we would need to consider testosterone replacement therapy. And of course, if we give testosterone replacement therapy, you would be checked on your testosterone level, but also your PSA level. And we would make sure that the dosing for the testosterone and that the cancer risk stays very low or mitigated. So for gentlemen with low testosterone replacement therapy is definitely a consideration, especially in somebody who's had their prostate cancer treated with either surgery or radiation. Next question I have is, I have a urologist. Oh, sorry, testosterone. I have a urologist, and there's a surgeon that did my prostate surgery. Oh, okay. So that often happens. Your primary urologist may have diagnosed your prostate cancer, maybe did the biopsies, and then another urologist did the surgery who kind of specializes in the robot. Is testosterone therapy you're talking about something I should discuss with either urologist, surgeon, or both? I would approach it mostly with your primary urologist. The surgeon you can entertain that question with the surgeon too, but the surgeon is kind of focused more on surgical skill and surgical ability to remove someone's prostate and get the cancer out. And your primary urologist is probably looking at your whole genital urinary system and completeness, including your testosterone. So I'd lean toward discussing it with your primary urologist first and seeing how comfortable he is about replacing your testosterone, and indeed if it's low. Again, the pattern for giving testosterone therapy for somebody who needs it after prostate cancer treatments would be, again, to test the testosterone levels after the therapy, but also to track the PSA very closely. All right. And I have another question, I think, in the chat. Can orgasm with outer core? Oh, I'm sorry. I can orgasm with outer course. So that's like mutual masturbation or oral sex, but not with intercourse. Can drugs other than cannabis help achieve intercourse orgasm? Oh, that's a very good question. And it's actually very controversial. There are other drugs that can help with orgasm, penetrative orgasm. Again, I kind of mentioned them briefly in my introduction, but sometimes I use an antidepressant called Wellbutrin. What that basically does is help raise dopamine levels. And when you raise dopamine, then the ability to reach climax is easier. The studies suggest that that can be beneficial in about 50 to 60% of men who have what we call dysorgasmia or delayed orgasm. By definition, delayed orgasm occurs in gentlemen who take over 20 minutes to reach climax. Average time to reach climax is about 5 minutes, and then premature orgasm is for gentlemen who reach orgasm in less than 1 to 2 minutes. So there are some medicines that can aid in heightening your ability to reach climax by elevating this threshold of dopamine. But the interesting part of your question is, can other drugs other than cannabis help? Cannabis is actually a mixed bag. Cannabis or marijuana can actually lower testosterone, and it can also lower orgasmic control. So cannabis can help gentlemen who have anxiety or really deep concern about sexual performance, but it can actually hurt gentlemen if they're having a slight problem with orgasm to begin with, or even erections to begin with. It's actually considered more of a suppressant to sexual function than a help. And so if you're on or using cannabis on a daily basis or even a 2 or 3 times a week basis, I would definitely have your testosterone checked. And that brings me to the topic of, will men reach orgasm with low testosterone? That's possible, but obviously with normal testosterone, it is easier to reach orgasm. Mostly because the erotic thoughts and desire and the libido improves when a gentleman has a normal level of testosterone. See if there's any other questions I'm missing. Okay, I think no. All right, so I've hit all the questions, I believe. Oh, nope, some more, I'm sorry. If I did a vacuum erection device or traction device are used to increase length, is that loss with the discontinuation? Oh, yeah, a little bit. So I like to tell my patients that when you're a young man, and you probably all remember this to some degree, when you're a 19-year-old, 18-year-old, you're getting 5 to 6 erections every single night as you sleep. You don't notice them because you're sleeping. And that event of getting a good full erection is putting stretch on your collagen fibers, your elastic fibers that are in your penis, your smooth muscles that are in your penis, and obviously the blood vessels that get stretched. So that repetitive stretching nature is kind of like a physical therapy for your penis. Now, as we get older, we start to lose that ability. We don't wake up with morning erections, and definitely after some prostate cancer treatments like radiation or surgery, your ability to get regular spontaneous erections starts to fall. And that's where we start to see penile shortening if we let that happen too long. There was a very, very interesting study done in the late 90s, and I don't know how gentlemen signed up for this study, but they did. These were gentlemen who had prostate cancer, and they underwent a penis biopsy before the surgery. And then they waited 6 months and they did the biopsy again. So we're talking about two penis biopsies that were done to study the smooth muscles within the penis. And what they found is that there was a decrement, a loss of penile smooth muscles after prostate surgery, after prostate cancer surgery. And that's because the men's erections started to fade or go away. And so if your muscles in your penis aren't being used on a regular basis, which basically means if your smooth muscles in your penis aren't being stretched on a regular basis, then they do start to atrophy and you can have penile length loss and penile atrophy. So if you discontinue a traction device or you discontinue a vacuum device, if that's your only method of getting penile stretch, then you can have loss of penile length. Now, if you're getting erections, then that's going to help. That's going to take care of the penile stretch. What impact can a penile, what is the impact of a penile prosthesis? So penile prosthesis is placed into the two cylinders of your penis called cavernosa bodies or corpora cavernosa. And those are cylinders that you can inflate with saline or they're rigid cylinders. And so that's taking over the event of filling your penis. I will tell you that when I replace a penile prosthesis, so penile prostheses can be placed and they generally have a lifespan of about 10 or maybe even up to 12 years. And then, they can malfunction or they need to be replaced. It's very interesting in our studies that when we replace a penile prosthesis, the prosthesis that we replace it with is actually bigger. And that's because the penile prosthesis over time has stretched out the penis again. And so the penile prosthesis can actually help you gain a little length. Now, you're not going to gain like 2 inches, but it can make the penis more full over time because we're stretching out those bodies. Is tissue retracted against the device? I'm not quite sure about that question. Your penis should be, if you're using a traction device or if you're using a vacuum erection device, I'm not sure if you're asking about is the penile prosthesis. Penile prosthesis is internal, so the tissue is stretched with the device. I hope that answers that question. You mentioned taking daily Cialis, 2 milligrams, question mark. Usually I do 5 milligrams to improve blood flow. Could you expand on the positives of doing that? And are there any negatives? Yes. So a very interesting study done in Europe. Over 500 men. There were 3 groups in this study. These are men who had had prostate cancer surgery, so had prostatectomy. It could have been a robotic prostatectomy or it could have been an open prostatectomy, but the vast majority of the men did have a robotic prostatectomy. In these 3 groups, the men were divided up into one group got no therapy, no Cialis. They were told, we'll start the Cialis later after your surgery. The next group were told to take Cialis as they wanted to. And that was to start right after the surgery. As soon as the catheter came out, the Foley catheter came out, they were told to start Cialis as you want to. And then the last group was given daily Cialis. And what they found in these 3 groups, that erection recovery and penile length was preserved in the last 2 groups, the groups that got drug. And so the group that didn't get any drug, the penises who had difficulty with erections and penile stretch. And that kind of makes sense, kind of going back to this whole thought that if you have regular penile stretch, it keeps the penis healthy. So by giving Cialis therapy right after surgery, daily or on demand, you can preserve penile function. Uh, what was interesting that the group that got daily Cialis did just a little bit better than the group that took it on demand. And so if you look back and said, well, the group that took it on demand, how many pills did they actually take? Turns out that they took 2 to 3 pills a week. And we know the half-life of Cialis is 36 hours. So basically, they kind of had their Cialis in their body almost all the time too. So I feel that taking it daily, it's just an easy way to remember to do something. And by doing it that way, I'm pretty assured there's drug in there. So that's the positives. The positives are we're reestablishing some better blood flow into the penile tissue that can add with oxygenation of the tissues, oxygenation of the muscles, and stretch if you're getting some expansion. The negatives are basically just the negatives of the side effects of the drug. And the side effects can be headache, uh, facial facial flushing. Some men can get muscle aches. Those side effects are pretty low, fortunately. The vast majority of men who even take it daily, it's less than 8% of men have side effects that they would stop the drug for. So I'm in favor of using daily Cialis therapy for most of my patients, unless there's some other reason why they can't. You can never mix these medications with nitroglycerin products. So if a gentleman carries nitroglycerin pills or paste for heart disease, then I can't use those medicines. Uh, but I also want one little caveat on that therapy. If men use daily Cialis, it's not the pill, it's not the chemical in the pill that's doing the rehab and preserving the penis. It's the action of getting penile fullness. So if men take daily Cialis and they come back and see me in 2 months and they tell me it didn't do anything, they get no penile fullness, they get no penile stretch, well, then we have to move on. We have to find something that's going to do that. But many of them will find that having daily Cialis, they might get some penile fullness, especially in the morning hours or in the nighttime, and that's a very big benefit for a lot of gentlemen. Next question is, sometimes I wonder if I should just accept the fact that oh, I'm sorry. Sometimes I just wonder if I should just, quote, accept the facts. I'm interested in sex and I look at erotic material, but I can no longer perform. Maybe I should just give up. My urologist seems to have that attitude. You had a good run, just accept facts. Old dudes aren't expected to have kids. Well, who would want a kid? I mean, you need a lot of energy to run around after kids. So I don't know you want a kid in your 50s, 60s, or 70s, but maybe you do. My thoughts, and the question is my thoughts. Listen, um, I don't place any judgment on patients. I will tell you the youngest person I put a penile prosthesis in was a 29-year-old combat veteran who had major trauma. And we did injections on him at first, and the injections were beneficial, but they weren't spontaneous. We kind of talked about that. And he wanted spontaneity back, and so we did it, and he was very, very happy with the penile prosthesis. But there was a lot of decision to do that. The oldest person I put a penile prosthesis in was an 86-year-old, and he was very happy. So it's all balance. You have to hear about risk and you have to hear about benefit. And you then with your urologist who does these surgeries more commonly or does injection therapy more commonly for their patients that they care for. So I'm talking about sexual health urologists. Then you should go forward with those treatments if that's what you want to do, knowing that there's risk, albeit usually very low, but there could be significant benefits. It's all a balancing out. I don't ever give up on sexual health because that's my job. We've done a ton of research on how men get erections, how men get orgasms, and how it works. We need to do more research, but there is a whole body of urologists who spend a lot of effort and time to try to figure this out for people. So I don't give up unless my patients say, well, I've had enough, and that happens, and that's totally fine. These are therapies that aren't essential necessarily, but in some men, they kind of are because it brings back quality of life. And so knowing the risk and knowing the benefits, if a man wants to pursue injection therapy or pellet therapies or surgeries to bring back sexual activity, then we do it. Like I said, there's a whole group of us sexual health urologists. I think you may have met other ones on this webinar or prior webinars that we spend a lot of time on reading our research and doing our research just in the efforts to make sexual health easier and better for men and women. The next question is, any thoughts about low-intensity shockwave lithotripsy? I participated in a clinical trial that helped function. Well, that's great. I'm glad it helped function. The biggest study we have on low-intensity shockwave therapy is from the University of Miami, which just got released about a year ago, which showed there's some minimal benefit. And so in gentlemen who have mild erectile dysfunction, the shockwave therapy can be beneficial. Could some men with moderate erectile dysfunction or even severe maybe have some benefit? That's possible, but just not as likely. There's a couple caveats here. Low intensity shockwave low intensity shockwave lithotripsy or shockwave therapy really has been found in the lab to help regenerate blood flow. And that's why it kind of took off with the possibility of helping men with erectile dysfunction. The type of shockwave therapy you need to use, however, is called focused beam low intensity shockwave. And there's two machines out there in the public, and one is a radial shockwave or radial wave. The other one is this focused beam. All our studies done for sexual health are on focused beam shockwave therapy. So if you're in a clinical trial, then they're going to use that one. I mean, that's almost a given. But if you're just seeing a clinic that advertises shockwave therapy, you really need to ask, are you using focused beam or are you using radial beam? Because radial beam is not what you want for any improvement in sexual erections. And the studies with it are a little promising, but we're trying to really figure out how many cycles do you need, how much shockwave intensity do you need, and that's still not known. And so if it's done within a clinical study, I'm all for it, and I think that's great. If it's done by a clinic that just happens to have a machine, then there's more questions to ask to make sure you're getting the right therapy. Generally, it's usually 6 treatments. They place the shock wave on different regions of the penis, but also on the base of the penis, which is in the lower pelvis. So, if anybody's going to get these therapies and they only place it on like 2 parts of your penis, they're not doing it right. And if you don't know what kind of machine they're using, again, you want focused low intensity shock wave, then they're not doing it right either. So you have to do a little research on this. It's not an FDA approved therapy, and that's why clinical trials exist, because we're trying to figure it out. What you'll see on some of the advertisement, FDA approved, that's not the same as FDA, I'm sorry, they'll say FDA sanctioned, or they'll use a different term. What you want to see if a drug is working or if a treatment's working, FDA approved, but no low intensity shockwave therapy has been approved by the FDA for the purpose of erectile dysfunction. So it should be done in a clinical trial, in my opinion. Or you have to go to a clinic that really does know what they're doing for erections. We use shockwave therapy on plantar fasciitis and on tendonitis. We use it for wound healing. That's been done. Some studies demonstrate that it can help regenerate tissue so the wounds can go heal faster. But those, again, shockwaves are a little different than the ones we use for penile health. Okay, next question. Thank you for being so, quote, sex positive regardless of age. I hate being impotent now. It makes me sad. Yeah, that's why we're here, to not make you sad and try to make you happier. But everything's got to be done in balance. And you have to, understand the risks and benefits. I've often one of the most common quotes I hear when men get to my clinic is, "It took me forever to find you." Not that they were looking for me, but they were looking for somebody that might have some answers for them. It doesn't mean they always do the therapies that I might suggest. That's not what I'm saying. They just want to know what options they have. Everybody wants to have options. That's always a good thing. And just sometimes by hearing the options and knowing where we're at is always a very good thing. And you got to remember that urologists have a lot of different disease processes that we take care of, from prostate cancer, bladder cancer, kidney cancer, but also kidney stones and renal function and renal preservation and transplant. And this is just another, I'm not trying to belittle my field. I think our field is great, sexual health urologists, and what we do and what we can offer. But sometimes it takes a little investigation to find that urologist who specializes in that. Fortunately, a lot of the academic centers in the larger cities, Boston, Philadelphia, Washington, University of Virginia, they'll have a sexual health urologist, or sometimes we're called andrologists. My next question is, I've tried shockwave. Oh, and thanks for being sex positive. Well, sex should be positive. Um, it should be enjoyable. It should be as easy as possible. As we get older, it's not as easy as it was when you were 20 years old. Um, and youth is wasted on the young. You've heard that. I love that saying because it's so true. Um, but that doesn't mean we can't get something back. I want a quick story about some of my patients, in particular the patients that go forward with penile prosthesis, which is not for everybody, but can be something, or it is an option for some men. When the wife is in with the counseling session, which I usually recommend, well, I always recommend actually, she kind of is always kind of thinking, oh, great, we're going to put this device in, and now he's going to have sex or want to have sex every single night. And that's not true. Most men just want to have the ability to have sex occasionally, or once a week, or once a month. And with that ability, their attitude just heightens because we've brought back a function that you enjoy. It's sort of like somebody who needs a hip replacement and their hip hurts so much they can't walk to the grocery store. And then we've given them a hip replacement and now they can walk again. So we brought back a quality of life issue that they can really enjoy. So I usually have to tell the wife, listen, calm down. I don't even think at age 30 he was having sex every single day. And even then she kind of nods. Oh, that's true. We had 2 kids and we couldn't do it. So it's not that we put a prosthesis and make somebody into a bionic sexual machine. But it can bring back the ability to have sex when you want. Another question, actually, it's a comment. I've tried the Shockwave stuff, $2,000 wasted. Yeah, and that's what I'm kind of getting at. You've heard the saying sex sells, and it definitely does. You can put an advertisement in any men's health magazine or on the web and say, we'll give you your erections back. It was shockwave therapy. And it's a hot topic. I mean, when I go to my meetings that we talk about sexual function and our research and penile prosthesis and the newest prosthesis, they're always inventing new techniques with the prosthesis, which is great. They're also inventing, or we're looking at, can we change our injections, or can we add a different drug? So we're doing all this research. This is a hot topic amongst us, amongst the sexual health urologists. We do think there's probably a component where this can play, but it's a little overhyped right now, I think, in my opinion. I think it's out there. People hear it. They think it's going to make me back to the way I was. That's a very tall ask. And I think it can help some men with mild erectile dysfunction, but we're still trying to work out how many shocks you need, at what focus beep, what location do we need to put it on the penis? Like I said, there's usually like 6 locations that we do. How do you need a tune-up? Let's say you do 6 sessions and you got a little benefit. You're pretty happy with that. Do we have to do it again next year? We're trying to figure that all out. And so this is very new science. And it's not quite ready for prime time, but the advertisers would make you think so. This is just one of the things that we always face with sexual health, that there's a lot of misinformation out there. And so if you are Googling, low intensity shockwave lithotripsy, low intensity shockwave therapy, you're going to get millions of hits. I would really try to guide you toward those academic centers that are doing it on a research protocol. So places like, Baylor, University of Miami, Cleveland Clinic, all these places, they'll have much better accurate information than, the sex health men's clinic down the street that also does Botox. You know, those are the places I worry about a little bit. Let's see, I have something in the chat. Let's see if I can open this. For men over 40, what are some recommendation tea supplements? Oh, and what are the possible negative side effects? Thanks. There's really, the term testosterone supplement is not an ideal term. It's actually testosterone replacement therapy. So when a gentleman has low testosterone, we're actually giving them back testosterone. We're not supplementing. And so when you see these supplements, and actually I did have a little slide about this, it's overplayed. They're usually using weak androgens, so weak steroids, and that might give you a boost for a week or two, or maybe even a couple months, but then it's going to fade because they're really not effective. So in my opinion, the only way to really treat somebody with low testosterone is to do testosterone replacement therapy. The supplements are mostly vitamins and maybe some minerals. If you flip and then they'll add some herbs like ginkgo biloba or any of these kind of herb supplements. It's not been shown beneficial. There's a whole division at the NIH, National Institutes of Health, that do look at supplements and can they prevent cancer? Can they help with sexual health? Can they change testosterone levels? And to date, there's been no supplement that we have found that actually does those things. There's no supplement that prevents cancer. Now, that doesn't mean I'm not advocating a good, healthy diet. I'm not advocating maybe a multivitamin. I mean, those nutritional benefits are definitely there. And so that's what I tell gentlemen who want to know what diet they should take to help preserve their testosterone. I always steer them back to a good, healthy diet. And as that nutritionists are starting to find out, and we're finding out, it tends to lean toward the Mediterranean diet. And I mean, this is not a study. I'm not quoting a study here, but some of the countries that have the most sex are Greece, Italy, and Spain. And so you got to wonder, maybe there's something in the food. So maybe there's something in the diet that they're having more sex. Personally, I think those regions of the world, that Mediterranean region, they're having more sex because they go home in the middle of the day for their fiesta and they're not quite sleeping. They're doing other stuff. So I think that's why their sex number is probably higher than other countries. But I can't deny that their diet is actually very heart healthy and very vascular healthy. There's a nice documentary out now on Netflix called The Blue Zones. That book came out probably about 10 or 12 years ago about these regions in the world where men and women can live into their 90s and 100s, and they have very low rates of cancer and very low rates of diabetes and heart disease. And this guy who's an epidemiologist, he coined this phrase, the blue zones. Well, two of those zones happen to be in the Mediterranean, Sardinia, Italy, and Icaria, Greece, these two islands. And so if you look at their diet, it's very heart healthy. It's rich in monosaturated fats, very low in red meats, but they're protein sources for plant-based, maybe some fish, things like that. So those things, Okinawa, Japan, somebody just in the chat, that's right. Okinawa, Japan was another one. Loma Linda, California. So the United States is represented. Loma Linda, California, which is very much farm to table eating. And then the other place is a town in Costa Rica, Nicola, Costa Rica. If you look at these regions, it's not just the food. It's their whole attitude of living. They're very social, very committed. They're very, I think in Sardinia, Italy, they don't even have a term for retirement. They get up and do something every day. So it's not just food, although that's a big component of it. I think that's something to consider. But they're very social beings. They drink a little glass of wine and talk all night. I mean, that sounds like a nice evening to me. But anyway, that's something to think about. I applaud you guys over 70 who are still pursuing sexual function. It's inspiring. Well, yeah. I mean, sex is inspiring. So for me, I had rectal cancer radiation, chemotherapy, and immunotherapy, and liver surgery. I am happy not to need rectal surgery. And I hope that sex after cancer would be the same as it was before cancer. So now I'm a bit disappointed. I know you focused tonight on prostate cancer, but do you see sexual function reductions with radiation? Yes, radiation can affect sexual dysfunction, especially to the pelvis. And chemotherapy, um, it diminishes some of your vascular function. And of course, the penis is a vascular organ. It's a microvascular organ, and that's why it doesn't work so great for gentlemen who have diabetes and poorly controlled diabetes. So all these factors, age, all these factors, sex does change. It changes for every man and woman as we age. There's no getting around it. Our bodies just aren't like they were when we were 19 or 20. It doesn't mean you have to give up on it. It doesn't mean that it's still not can't be enjoyable. It might need a little bit more prep work. You might have to use different lubricants. You might have to use an injection to get a good erection. But if that 20 minutes or 30, 40 minutes, if you're really good, is enjoyable with that prep work, well, then more power to you. And if that's something that you want to focus on and try to make happen, well, then there are physicians here to make that, to answer those questions and help you decide what therapy to do. Um, it's not, like I said, it's not for everyone. I mean, if some people say, oh, that's just too much work, I don't really need to do that anymore, and that's fine. That's their choice. But I think we should always have a choice. And I have 70 and 80-year-olds who still enjoy a sex life. It's not like their sex life when they were 20, but they still enjoy it. And it brings back intimacy and bonding. You release so many great endorphins during sex. Some people get that endorphin release when they run. That never happened to me, and that's why I'm a little overweight. But you see my point, that if something feels good, it generally is good. And sex is one of those things. Now, it may take more prep work. It may take more medicines. It may take some more surgical interventions. But if that's something that's important and the risks are low, then we try those things. Do patients report that post-prostatectomy orgasm is somewhat less satisfying? The quick answer to that is yes. And only had 2 orgasms since my surgery 6 weeks ago. Oh, well, you're actually doing very well then, because it's only been 6 weeks. And at least I think I had them. Yeah. So this is a very common question or a comment that I hear, is that the orgasm is now different as my prostate is gone. It's true. You will not have any ejaculation because the prostate makes the semen and the semen's not there anymore. And of course, you want to ejaculate it because it's not there. But the orgasm, the sensation, this euphoric feeling, and this kind of rhythmic contraction that happens in the pelvis, that's mediated by brain function. And so when you hit that, you'll still have orgasm. I will tell you that a lot of men are very product oriented. You want to see something happen. You're so used to it, I think, is the real answer. You're so used to seeing something happen or something come out the penis at orgasm. So then, therefore, the orgasm feels different because it's not quite the same. I probably would agree with you. It probably isn't quite the same. But as men get past their surgery and still experiencing these orgasms, it kind of becomes the new normal. Um, and they still enjoy it. And so, we move from there. But it's a very good question. Do patients report post-prostatectomy orgasm is somewhat less satisfying? I'm going to tell you the quick answer is yes. But with time, it becomes satisfying. It's kind of like it's a new feeling because it's different, a little different than it was before the surgery. Would you speak to the total and free testosterone? Wow, someone's doing research. And how many patients should look and how a patient should look at these numbers. Okay, so total testosterone is a combination of testosterone that's bound to proteins, and those proteins are called sex hormone binding globulin and albumin. So if a testosterone molecule is bound to proteins, it doesn't quite get into your tissues anymore. It floats in your bloodstream, but it doesn't go into your bones and your muscles and your brain, your penis. Then you have another component of testosterone, which is called free testosterone. So free testosterone is not bound to proteins. So your total testosterone is adding those two together. And then we can fractionate the testosterone molecule test and figure out what percent of your testosterone is free, or how much free testosterone you have. This is where the problem comes in. That free testosterone test is usually very difficult to do and expensive. And so some of those assays are not as accurate as we would like. And so I have to use kind of a combination of your total and your free level. And again, I want your total usually above 350, definitely above 300. And that's nanograms per deciliter. And then your percent free testosterone usually should be above 8 and sometimes up to about 20. So that range. It's very, also, you have to keep in mind, testosterone is very labile. It fluctuates like crazy. So I never base my testosterone theory for a gentleman on just one test. It's just that one test is a snapshot in time. If you had a fever, got a bad cold and sniffles and headache and fever, your testosterone falls. If you twisted your ankle, your testosterone falls. If you didn't sleep really well the night before your test, your testosterone falls. So testosterone is very sensitive to a lot of things that your body is experiencing. So I never base my therapy just on one test. I want two tests to prove to me that testosterone is indeed low. And if I see that, then I will discuss therapies. The free testosterone, I sometimes will test those proteins I mentioned. And if I know those proteins and I know the testosterone, then I can calculate the free. But for most people, I mean, for doctors, we look at that. We look at the free testosterone. We like to think about what it means and how to handle it. The truth of the matter is most of our therapies and most of our studies were based on the total number. So I think for most people, just following your total is going to be accurate, very accurate, to help know if you're getting the right amounts of testosterone. We look at free testosterone more commonly in patients, for example, who have liver disease, or have other ailments, because then it means a little bit more to us, because those proteins I mentioned would be different. Those proteins I mentioned are actually produced in the liver, so it kind of makes sense. If you have liver disease, this test or testing testosterone is going to be different. Don't read this one if you don't want to. Well, I don't know why I wouldn't want to, but I hope everyone can. Okay. Don't read this one if you don't want to, but I used to be a top in a gay relationship and I could no longer perform without a prostate. How can we manage? No. So if you're talking about not being able to get a good erection, then we would help with that. I mean, this research is, we are researching now gay relationships, and that's a wonderful thing to research because it's a little different than heterosexual relationships. The amount of pressure that you need to engage in anal intercourse in a man or a woman, the amount of pressure that the penis needs to handle the buckling strength, if you will, is stronger. And so we would have to, work with the patient and the couple to see if we can make that come back. But I have done that with my couples that come in same-sex marriages and same-sex relationships. And, we work with it. The prostate is a sensory organ for a lot of men. Gay men understand that very well. The prostate can bring a kind of, sometimes it's called the male G spot. And it's an erogenous zone, basically. The erogenous zones in a man's body are very variable to everybody. Some men could get really stimulated with, their nipples being touched or their armpits or the back of their neck or the back of their knees. The scrotum can have a lot of sensation. Generally, the head of the penis, especially right under the head of the penis, this area called the frenular area, that has the most sensation. That's a very erogenous zone, but the prostate is an erogenous zone. And so when it's missing, you've lost one of your erogenous zones. So we have to teach you other erogenous zones that can make sex very enjoyable and erotic again. Um, in my time in the military at Walter Reed, we took care of a lot of gentlemen, of course, who had combat wounds. And they lost erogenous zones because their arm was missing or their leg was missing. And sometimes they had pelvic injuries. And so we had to then teach them new ways to have sex because it's what they wanted. These are young men who want to have sex. So we looked into toys that they could use. Vibration is a very powerful stimulant for eroticism. And we had to find vibrators that they could hold because their hand might have had an injury. And so we make one of our nurses that helped us with this, we called it the intimacy clinic because we couldn't say sex clinic for some reason, although that's what we were really talking about. But intimacy clinic, we came up with this whole kind of, we reviewed sex toys, which ones the man could handle and hold easier if he was missing a finger or two, or these chairs that would glide, and now he could have thrustful sex because he was missing two legs. This is all good stuff and should never be ignored if people are having an enjoyment with it. And it shouldn't be closeted, and that's not the term toward a gay relationship per se, but sex in general. Sex is a normal thing, and because it's normal, we should be able to talk about it. Not at any age, but at a particular age, we should be able to talk about it freely and understand. Now, you might want to reserve it. It is a personal function, and that's fine. I don't think it needs to be up on billboards. And although you'll see, Men's Health Clinic, shockwave therapy on billboards. But I don't think we should stigmatize it either. I don't want to get on any soapbox anywhere, but I think we talk about school shootings with great ease, but we won't talk about orgasm. I think there's a little problem there. And so my clinic, it's a free reign. If somebody wants to tell me something about their sex life, they can do so without any judgment. Because after all, I think my job is to help people with sexual function. And if we can't talk freely about what they want out of sex, then I don't think I can help people.
Amazing. That was our last question. I just want to give a huge thank you to you, Dr. Dane, and really to everyone's bravery for asking such incredible questions tonight.
It was a really great group of questions. I've done this for a long time. Usually I'm in an audience with and that probably stifles people. Maybe the Zoom is better. They feel like, oh, it's anonymous. I can just type in any question. Usually in a crowd, I don't get, these are great questions. And there's a lot of research questions, which I really love. Somebody's doing some research. Careful on the internet, though. Please stay at sites that are reputable, like the Cleveland Clinic or the University of Virginia or University of Miami. Be careful of the, come visit me and I'll make your sex amazing clinics. Those aren't quite accurate. But anyway, yeah.
Great.
I love the questions. That's the bottom line. I love the questions. They were great.
I love that. And we really appreciate you being here to answer them. I think we talked a lot tonight about the physical aspects and just want to remind people about the emotional and social aspects, which you talked a little bit about, but there is a lot of grief and sadness. And so certainly psychotherapy or sex therapy is an option to go along with medical treatment that you're receiving, which can be helpful in a number of ways to folks.
It's totally true. I didn't touch on that much because I'm a urologist and I focus on physical functions, but I always talk about in my clinic about sex therapy and psychotherapy and emotional bonding and intimacy. I don't do those things. I don't do those therapies, but they're extremely important.
Yeah, I know that you bring them up often. So just wanted to note those here, since I dabble more in the therapist lane and you're really in the medical lane, and those two complement each other so beautifully in this space. So thank you for joining us this evening. Thanks for everyone who logged in. We hope to have more conversations like this in the future. And certainly you can pop over to lifewithcancer.org to see of upcoming programs in the sexual health space, but also just in the supportive realm of cancer. So I hope everyone has a really lovely evening.
Thanks again, everyone, for the questions. Have a good evening.